And of course, again, legislation is so important in every state that you have legislation that mandates coverage. We are very fortunate to have that done about 6 years ago. This network, again, is open access. Anybody can connect to anybody. Can you see the map now? Yep. Okay, this kind of shows you where we are, and you can see the little diamonds are where the nursing homes are now. We have, I believe there's 18 nursing homes participating in the network. We started doing telemedicine in a nursing home about 3 years ago and did a pilot project in a 5-county region, and I'm going to talk to you about that in just a little bit. The pilot that we did, we just felt so strongly that reducing unnecessary ER visits and really unnecessary transporting of these patients was so important. I know you can only imagine that nursing home patients, to get them in a ambulance, put them on a stretcher, take them to an emergency room, have them sit there for hours to see a doctor, and then a very high percentage of the time, close to 70% of the time, these patients are returned to the nursing home where they're able to receive treatment right there in the nursing home. So we thought if there was a way that the patients could see the emergency room physicians by video, and to be able to, for the physician to listen to chest and heart sounds, to see wounds, that this would make a big difference, and the ER physicians could make necessary treatment recommendations, and most every time could be done right there in the nursing home. We have actually seen patients who are transported to nursing homes come back with injuries. It is so traumatic, and it's so hard on them, and unfortunately a lot of these patients don't have families who you can call to go with them. It's just tough. But we started a partnership with Ethica Nursing Homes, and Ethica in Georgia manages quite a few nursing homes. I think there's over 100 of them, and they have probably about 35 skilled nursing facilities in Georgia. So they were very interested in this, and we were able to help with and grant them some equipment that we had, some older equipment that we had, just to kind of try and see if it would work. And the Medical College of Georgia now, who is Georgia Health Sciences University, there was an emergency room physician there who was older, and he had a real heart's desire to make a difference in nursing homes and wanted to participate in the project, and agreed and got his emergency room to agree to be able to see patients in nursing homes for emergency kinds of situations. You know, the problem definitely was all about trying to keep patients comfortable, not getting them in a situation where their problem sometimes is worse after they're transported than it was before they left. We're going to talk about what was done to get there, did it work, and then we'll talk about how it was done. The problem, of course, is many unnecessary transfers and leading to very high expenditures and patient stress. And we know that getting care in the nursing home, for the nursing home itself, for them to go to the emergency room was tough. Most nursing homes, they get paid a certain amount of money. It doesn't matter if they're in the nursing home, if they're in the emergency room, at the hospital, and the expenses even to send someone to go with them can be quite high. It did work. Our first 5 sites, in about a 3-month period, we did 20 consultations, and the ER physicians concluded that 10 patients did not need to come to the ER, and likely all of these would have been transferred to the ER. Since then, this has been about a year ago, we have done about 75 ER consults, and we have grown from 5 sites to 18 sites. So we'll see these numbers go up. And every time that we take a look at this, it's around 60% of the patients do not need to go to the ER. They could be treated right there in the nursing home. What we did, of course, was figuring out a way to obtain patient consent or guardianship consent. And so when the patients are admitted to the nursing homes, this is one of the things that the guardians or the patients themselves are talked about. If you need to see a physician, are you willing to see them in this way? And of course, we can say in the beginning it was they weren't quite sure about it, but the guardians, the patients, you'd just be so surprised at how well these elderly people accept being seen on TV. It's quite interesting for them, and they love it. And most of the patients and most of the guardians and the nurses and providers at the nursing home tell us that they don't know what they would do without it, what they did before without telemedicine. Of course, determine the need for the consultations, and most of them were for potential, heart problems, potential pneumonia, infections, these kinds of things. So contacting the ED immediately, when something goes on like this, and then literally conducting the consultation. How we did it was, obtaining stakeholder support. I tell you, we've had a really tough time getting some of the other nursing homes to buy into participating in telemedicine, and I think you'll see that, most everywhere you go. But if you can at least have 1 or 2 nursing homes with some successes, you're going to definitely see this kind of roll into many other locations, as we're seeing nursing homes are a big opportunity for growth and acceptance of telemedicine, and the nursing home is becoming much better. We assist with central credentialing if anything needs to be done in the nursing home with the credentialing.
Paula?
Yes.
Paula, hey, I'm sorry. Hey, there's someone out there who's not muted anyway. We're hearing some other audio out there. I just want to remind everybody in the interactive crowd to mute their mics.
Looks like water, doesn't it?
Okay, go for it. Sorry to interrupt. Sorry, Paula.
Oh, that's okay. Thank you. And then, of course, we had to develop protocols for the consultation, so the staff in the nursing homes would know the steps to take. And one of the other reasons for successes in that pilot project is that physician I was telling you about, who had taken such an interest in providing services to nursing homes, literally visited to all the pilot locations multiple times. And really it took us about a year to get it up and running to the point that we wanted it, because again, when you're working with multiple staffs on different shifts, trying to get people into a different mindset that you can actually go to the ER this way was somewhat of a struggle, because I think it was easier for some of the staff to say just send them to a nursing home and pick up the phone and call the ambulance to come get them. So it definitely takes some effort, and it also takes, very good administrative support from the top down, really, to get the staff in the nursing homes to do what's needed to be done to provide these kinds of services. Some of the benefits are, increased access to physician availability. It prevents unnecessary transportation. It can be so difficult for these frail patients. Cost savings, definitely fewer ambulance trips, cost of staff to accompany, higher quality of care with access to specialties. And not only ER visits, but after the pilot project, we have implemented, some other specialties that have taken off and that are working so well. One great thing about, in nursing homes, it allows these problems to be addressed as they occur. I mean, just as soon, when something happens now, not only the emergency rooms, but the primary care physicians who are providing these services in the nursing home, they can connect to that primary care physician without him having to come to the nursing home. Just to say, look at a wound, your chest sounds again, and of course this does prevent delays in treatment, and there are a lot fewer complications. You don't see as many decubitus, how they can deteriorate so quickly once they develop one. If they can get a physician or a provider to provide services very quickly, I mean, the outcomes are so much better. And one of the exciting things on top of this is now with Skype and a lot of folks been able to connect in with Skype just to see their family members if they can't travel to get there to see them. For the patients who are able to be in a wheelchair, or literally they can take the carts that they have in the nursing home are very mobile. They could literally take them to the room, but they can connect actually with their families to utilize the network to do that, and I think that's been a real blessing for a lot of the nursing home patients. We use a lot of store and forward here in Georgia. Medicare does not pay store and forward, of course, but Medicaid and all commercials here, private payer, do pay for store and forward, and we've been able to do a lot of wound care, We have one hospital who has 5 affiliates, and they have a PhD who specializes in infectious disease, and I think they have 4 nursing homes besides hospitals in those rural counties. And so she gets a large number of photos of problems of patients in nursing homes. It has cut down her visit to there dramatically. Plus, they can catch problems so much quicker, monitor them. Literally, they can send pictures daily to her, and she can also direct the care of the decubitus or wound or whatever is going on in that patient. And the thing about wound care, it just pays. It's just a quality of service thing too. Even if they're not paid by, say, Medicare, they see the value. The nursing homes see the value of having this kind of connection, just to provide a great way of quality service. And the expense that they have to pay to take care of these wounds sometimes can be quite big. These are the top telemedicine encounters we had in nursing homes last year. Wound care was definitely big, the ER visits. Gerontology, psychiatry, that has been huge. A lot of that going on. We have connections. There's a gerontology clinic at Emory in Atlanta who provides a lot of gerontology psych clinics to these 18 nursing homes. Endocrinology, rheumatology, and of course dermatology. So in our minds, we know that it's making a huge difference, and we're finally seeing acceptance of using telemedicine in the nursing homes. These are some real pictures we did with some real patients, and you can tell just by looking on his face he loved it. So that's kind of what I had in mind to share with you today. I could definitely talk all day long about what we're doing here in the state of Georgia, outside of nursing homes. We have so proud of where we are, and appreciate any opportunity to share, and we also love any opportunity to share our lessons learned and to assist in any way that we can in other areas of the nation, or to help you get started if you've not done this before. We can share protocols. We're happy to help you in any way that we can.
Well, thank you. Yeah, here, I'm just fixing my camera. Where we whoop. Did you, can we go back to, I know you had mentioned wound care and some other stuff. Have you guys done any mental health stuff with nursing homes?
Oh, yes. I was saying about the gerontology psychiatry. We have large numbers in the 18 facilities of psych clinics. It has been such a blessing to, we started again with the 5 pilot sites we had in the nursing homes, but then we have expanded to the 18, and really wound care and psych are the largest needs that we have in the nursing home.
Yeah. I mean, we're talking to people who are seeing that too. Are there any other questions out there for Paula as we get at this point?
Hey, Paula.
Hey, girl, how are you?
Hi. I'm very interested to know about your Storing Forward. I'm very impressed, first of all, with your program. You and I talked via email yesterday. And I'm trying to steer Minnesota towards that direction because they don't understand it here. They don't get it, okay? I mean, it's embarrassing. The University of Minnesota, one of the biggest universities in the country, they don't have a telehealth program. It's very embarrassing. So anyway, Storing Forward, you mentioned that the private payers pay in Georgia?
Yes, yes.
Really?
Yes, and we were, the legislation, when it mandated payment for telehealth, included Storing Forward. And we had to definitely advocate with the Department of Community Health for Medicaid reimbursement, but they have also seen fit to pay for Storing Forward.
Wow, I'm amazed.
Well, you know, I've been doing this for 11 years, and it's been so persistent, they can't get rid of me, so they finally give in to it.
Right. Huh, I love it. Thank you.
Hey, you're welcome, and I'm looking forward to showing you the stroke portal. And this would be a good way to do it. We can connect, and Lloyd will be able to show you on live
Yes.
video how that stroke portal works.
I would love to see that. I would love to see that.
I was just going to tell the folks who are watching this on the internet, there's a button that says "Ask a Live Question." You can text in a live question, and I'll ask it. Paul, if you can see that, just to give you that heads up.
I see Zoe on the screen. Who is the other person?
We've got a group from Vermont there.
Yeah, hi. Okay, well, let me see here. I'll try to go back with the camera. Okay.
Hey, we see you.
Paula, I'm Judy Amor in Burlington, Vermont.
Yes.
I think we've emailed a long time ago, because I remember your
Yes.
name talking to
Yes.
you. I did have a question for your ED docs when they see, the residents of the nursing homes. Are they paid the same way through Medicare, Medicaid, private payer?
Yes, they are.
So-
They bill the same CPT codes, the 90, whatever the codes are that are covered. They bill the code for the evaluation, and they get paid that way.
Yeah, that's great. So you're not needing to do or contracts with different organizations. It's just taken care of with all your legislation that you already have for.
That's correct. We are so blessed to have that taken care of. We don't have to deal with any of the insurance companies if there are any issues with payment or reimbursement. We have the Commissioner of Insurance here on our side. We just submit a complaint to the insurance commissioner, and he takes care of it.
Oh, that's wonderful.
I would highly recommend, if you have an insurance commissioner, to go there and get his support immediately. And I tell you, you can talk about this stuff all day long, and Zoe, you know this too. You got to show them. You got to go in there to your insurance commissioner and any state level people you can get your hands on and literally show them the technology. And it's like the most negative people in the world will become your champion.
Well, let me ask you, this is interesting, Paula, that what you just mentioned. So, so you can do this, you know, isn't this, how do I say, lobbying? No?
Well, let me tell
I
you,
mean,
whatever it takes.
whatever it takes.
All right,
Well, the reason why I'm asking you this is because we just had a discussion today about something similar, and I was told that we can't really do anything like this because that's is lobbying.
Are you talking about for the resource center?
Yes, for the resource center.
I don't think so, but you know, I've done all this under Georgia Partnership for Telehealth's name. You know, we
Okay.
just received the resource center grant last year, but we've gotten all these changes, things done, you know, being Georgia Partnership for Telehealth, which was a not-for-profit, and I didn't know it was really, I didn't know if it was lobbying or what I was doing, but I was getting everybody that I could.
I agree with you.
Informed
I
about
agree with
telehealth.
you.
And I think if you don't do that, it's a lost cause, because you've got to impress people at high levels that this is a great way of providing access to care, and it's high quality, it's efficient, and it's cost effective. So if you can get them to understand that, and if they see it in action, I promise you it's happened over and over and over again.
You don't have to tell me that. I've done it. If they see it, they get it.
That's right.
Okay, hey Paula, I've got a couple questions from the online audience. One from Jim asking, were all of your encounters private pay? I know you kind of touched on that. Were all of your encounters private pay?
Oh no, oh no. All of the very few what I call private pay is people who are not insured, but commercials, you know, they're required to pay. Medicare and Medicaid pays. So we have very, very few people who private pay. We do have some physicians, unfortunately in this day and time, there's not a lot of physicians who will take even a private pay. They have to be either insurance covered or Medicare or Medicaid. And there's very few who will actually take a private pay. Isn't that terrible? But that's just kind of the way it is.
Yeah, no, that's similar to what we expect, or what we see down here. I've got another question from Sam online. He says, you mentioned many of the older folks were accepting of receiving care via video. What are some of the tips you can share to increase the likelihood of acceptance, you know, of these?
Okay, well, first of all, you have to make sure, you have to make sure they can hear. If they can hear the physician and it's loud enough, then they're very happy. The frustrations we've seen on our old systems was we couldn't get enough volume for them to hear, and they would be very dissatisfied. But once, now that we've addressed our audio issues, really getting them in there and seeing it and talking to the doctor. I mean, they're just kind of overwhelmed by it, that this could possibly be happening. So it really is just getting them in there, trying it one time. You can tell them you're going to do it, and they really don't want to do it. But if you take them in there and they have a good experience, it works great, and they're very happy.
Paula?
Yes.
We've used headsets before also with the elderly, you know, if there's a lot of noise or whatever. So
yes,
that's
absolutely.
I had another question. This is Judy from Vermont. When you were talking about what the, I think it was the ED physician that had a real heart for the nursing homes, and you had written down something about physician visited each location. Did you mean physically he went and visited each location and each shift? Each shift.
The man literally went multiple times to each shift. I think over about a 3-month period, he made at least 2 and sometimes 3 visits to each location. Yeah. And that's very important.
Right. I definitely agree. Okay. Thank you.
Mm-hmm. Yes, now.
Was I the mystery man that you were asking about earlier?
You were.
My name is Jeff Erdan. I'm with VIA. We're actually a software-based video conferencing and collaboration company that interoperates with H323. So I heard you mention earlier that some patients use Skype to visit with their family and friends. Have you looked at some of the, I mean, we're not the only ones who do this, there are several others who have a software solution that someone can use at home that will connect to your H323 system so that you could have your telehealth encounter shared only member remotely.
We personally, because like I say, being a not-for-profit, we have so focused on getting people started in the telehealth world, but we do see that this is the way we're going, and we know that we're literally using a new system on iPads. I mean, it's much higher quality than Skype, but for visits, family visits, things like that, Skype is perfect for that. So I'm always interested in seeing what's out there and what's the easiest thing. You know, the easier you can make this for families and even physicians, you got to make it easy for them, or they don't want to do it either. So I'm always interested in looking and seeing what's the latest and greatest out there and the most cost-effective, but yet, you know, good quality. So I'd love to see what you have.
Sure. Okay, I'd be happy to shoot you an email.
Okay.
Or just for anybody else who's not you, it's VEAMEA.com. You can see us on the web.
Okay. And Deborah, did you have any comments?
Sorry for the commercial.
Hi, this is Deb Peters from Pacific Basin. Going back to Zoe's thing about being told that you can't lobby, somebody from Oak told me that as well. But I think what it does is it kind of depends a little bit on your definition of lobbying. And I think, and the other thing is that one thing that we do, okay, is that if we have somebody who's going to go to the legislature, we can support an individual, we can support another organization. We just can't do it.
Okay.
That's what I was told, Deborah. Yeah, that's what we're going to be doing.
I mean, it's just, it's kind of, to be honest with you, it's kind of a workaround. I mean, we're not lobbying. I mean, somebody else is going to do it.
Yeah. Well, that's been I think the thing for us is GPT is actually the grantee for the Resource Center. But we've done all these things before the Resource Center ever came to be. And of course, people we're helping with the Resource Center. I mean, we're really just helping either way, whether it's GPT or not. But if you can get in, I don't know if it's lobbying or an informing. We're more informing. We were able to present to the full House, to the full legislature at our state capitol 2 years in a row. But it's informing them about telemedicine so they can make wise decisions. So anyway.
Well, in this particular case here, it's a little different. Actually, it's a reimbursement issue that we'll try to change in Minnesota. So, and I was told you can't do that as a GP track, as a resource center.
Well, I think we should address that at the next Resource Center meeting because how
I think we should, because I don't understand that. I think we should.
So crazy. I mean, why are we a resource center if we can't even resource ourselves?
Absolutely. It's kind of stupid. I'm sorry for my language. Yeah.
Okay, hey Paula, I've got another question from an online viewer. Brian wonders, have you had any difficulties training staff on the telemedicine equipment?
Well, again, we have been so blessed to have staff, you know, from that initial funding, and people who participate in our network pay a monthly fee. And so we have liaisons who are regional across the state who are out there educating and training folks. They get their initial trainings, of course, from the vendors, but we're in and out of there, and we're like first point of contact for any issues our network is. And so we're in there addressing them. But it is a barrier because you wind up having turnover in staff. You're constantly going back in training new people, and we've learned that we need to train somebody to train the trainer. And the neat thing about it is now that we as resource centers can provide more online training for the basics of telemedicine, and also I think do more hands-on kinds of things through video to provide these kinds of trainings to folks who are providing telemedicine. But it's tough to keep everybody trained as needs to be. But, with technology getting better and now we're using the iPads for our physicians, it's so much easier than it's ever been before. So that's been very helpful too.
Okay, anybody else out there? We've had some good questions so far. It's been a good discussion. Let me go back. Yeah, we've got a couple from Jim that I'm seeing. Actually has three. Okay. What was your average reimbursement for encounters? How did you cover your physician expense? If you want to tackle that one first, I've got two others after that.
Okay, well, we don't do any billing from this office. The physicians do their own billing, and they get paid the exact same thing as if a patient was in their office. So hopefully that answers the question. We don't do any billing. We provide them with codes, any information about billing we provide them, but they do their own billing. And there should be no difference in what they get paid, from telemedicine.
Okay, let me jump on to the next one. Jim's wondering what platform are you using? Polycom, Tandberg, LifeSize?
Okay, we use some of it all. I've used Polycom. We've used a lot of Tandberg, and the last 2 years we've used the Movi solution a lot. Now we're using video. Our new carts that we've gotten with grant money are from Rubbermaid. So Rubbermaid makes, they're in the, I never really realized it, but these carts that we're using are used all over the hospitals. There's thousands of them out there in hospitals that are being used for medicine carts, to roll around, and they literally have them on walls in patient rooms now. The Rubbermaid system does. So we've been real pleased with that cart, but they actually use, you can use LifeSize, Polycom, Tandberg, video, any of that with their carts, and it's touch screen and it's cheap. It's much more affordable. So but we advocate for all of them. They all operate together, and we try not to say one over another because, like I say, they all work and seem to work well. It's just according to your relationships and the service that you receive from whoever's providing you the equipment.
Right. Okay, another one from Jim, and I've got one from Sam, so just hang with me. Jim's last one, do you think you could run the nursing home program and not being grant funded? So without grant funding, could you run this nursing home program?
Okay, well, now that we have proven it, yes. When we started, absolutely not. We would not have been able to, I think, get the nursing homes to even try it without being able to provide them with the equipment because of the expense.
Yeah.
But now, it may not be necessary for them to have a full cart. They may need just psychiatry or derm. They may need just a laptop and a camera. So I think it's more affordable now. You can go from the extreme to the carts that are most expensive all the way down to, something very simple. So the buy-in now is different for us in Georgia because we've proven it. So we're seeing a difference now, but definitely we could not have done any of this without grants. Zoe, we have been grant funded. All of us have been grant funding in the telemedicine world since I started 7 years ago. And that's why we're so excited to be at the point now we've proven folks are willing to pay a fee to participate in the network. They're getting paid, for the services. And you're just going to see, once you can get your reimbursement issues resolved in the other states, this is definitely, it is the way that healthcare is going to be provided.
Yeah, it really is.
You know, the young people, this is all they're used to is technology.
Okay, got a quick question from Sam online. Sam wants to know, can you make any recommendation on a scheduling software or platform? I'm not sure if he means, like the Tandberg content scheduler, or if that's where he's going
Well,
with that.
all I can tell you is that for scheduling of telemedicine clinics, if you've got 175 physicians participating, 250 locations accessing those physicians, it can be a struggle. And of course, we didn't have a lot of money to pay for big scheduling systems. And so I can tell you we designed our own using SharePoint, and it works flawlessly.
Interesting.
All partners, yes, all partners are, it's web-based. All partners are on the scheduling site. We do the scheduling actually from this office, but all sites have access to it, and it works flawlessly, and we have very little money invested in it.
Wow. Can you share with us how big and so how big is your IT staff?
Well, because things work so well, I have 3.
Wow.
I have 3 in the IT department, but all of my liaisons are trained to do a lot of troubleshooting, but we only have 3 and we have so few technical issues. We've been able to, actually I had one forever, just hired one year before last and got a new one about 6 months ago.
Wow,
Paula,
that's...
I'm sorry.
Oh, sorry, no, go ahead, Zoe.
Well, this is the question actually I wanted to ask. Do you have a state network that you connect everybody through?
Well, we are not for profit that's separate from the state, but we have a lot of support from the state. So it is a statewide network. It literally is a statewide network. Everything flows, it's coordinated, the scheduling, the credentialing processes, all the partners who are participating in the network. It is a statewide network, but it's not, we're not really affiliated with the state other than they're very supportive of what we're doing, which has been a blessing. I promise if we had been I think, owned by the state, there is no way we would be where we are today. No intent. I don't know if I should say that or not, but going through committee after committee to make a decision, we have been able to, as this separate entity, if we had an opportunity to just take the ball and run with it, we didn't have to go through 10 different committees to do it. So I think that's been so important.
Okay, anybody else out there? We're nearing, I don't know, I've got about 6, 7 till here, and Paula's been really great taking all the questions, everybody's comments and discussion. I really appreciate it, Paula.
Oh, you're so welcome. Like I told you, we love sharing what we do, and anytime that we can be of assistance, please let us know. And I'm sure we'll be doing some of these along as we move forward.
Okay, I hear someone maybe unmuting there out in video conference world. Maybe there's a question. One last one.
I came in a little bit late. Just wanted to double check about the availability of the slides and recording after the fact.
Yeah.
I'm happy to send these to Adam, and maybe Adam can get them out, or we can post them on the website too.
We will have the recording back up. What I'm going to do is, I'm going to edit out that first 10 minutes of the recording where we were having connection issues. I don't want to promise Thursday. I could maybe try to get it up Thursday and maybe Monday though before the recording goes up. If Paula sends me her slides, I can forward them back out to you. So if you want to hit me on the website there on LearnTelehealth.org and connect with me, I can hook up with you.
Sure. Okay.
Okay. Well, hey everybody, thank you so much. We had some good folks on. Some good discussion. I appreciate it, Paula. And I will be touching base with you tomorrow. And I appreciate your